Good afternoon, everybody. Just like she introduced, my name is Victor, and nice to see everyone here. My background is sorry, I have a bit of a cough and cold. So, in case my voice is funny. So, my background is technical project management and software development. And just like she said, representing EHA Clinics. EHA Clinics is a primary healthcare organization in Nigeria. She started about 7 years ago and is JCI accredited. Started with one branch. Now there are about 9 branches, brick and mortar clinics, and um, I think right now it's dealing with about 45,000 patients across the 9 branches. They also have a program called REACH that is reaching everyone with accessible community health. So it's their version of providing subsidized healthcare to very low income communities. So those kind of communities, usually network connectivity is poor, electricity, and then, low income. And so the REACH program is more of a community-based outreach, and they also have brick and mortar clinics where they administer care. And then, just like she said, a couple of years ago, we worked on building our EMR on the Better platform. So we built that out, a team of less than 10. We were able to build that within a year. We used over 100 archetypes, and this is now live. So I will just move on very quickly. Just like everybody would know, from sub-Saharan Africa, 25% of the global disease burden, um, less than 2.3 health workers per 1,000. I think when I attended the um, Better conference, for those that were there, the Better conference in June, I said, there's some places in Nigeria where, the physician to patient ratio is about 1 to 30,000. So you have one physician to 30,000 patients. And so there's a huge, problem in terms of health workers and administering quality care. So that's the kind of, you can read more of this, but that's the kind of context where we operate. And so when we develop our solutions, we have to think about, the community, the context, and how to, still administer care at that kind of scale. Um, so one very interesting aspect of, healthcare in Nigeria is that because I've just explained about how health workers are not so much and healthcare facilities are also not optimal in quantity. You have a lot of people visit what we call, community pharmacies, or what we call them PPMVs, patent and proprietary medical vendors. So these are like community pharmacies within the community, and these are more accessible. So these PPMV vendors they have some sort of healthcare training. They live in the community. The patients, customers visit them, they trust them, and they are able to administer some level of, first level line of care. And so a lot of patients, just because of, some of the distances and the constraints to visit a health facility or, access medical personnel, they prefer to go to these PPMVs. So we thought that one way we could, reach people in this kind of communities would be to use these PPMVs. And so the key would be, how do you make them more effective? How do you make sure that they are administering care according to, standardized protocols, guidelines, and, things of that nature? And so what we decided to do was to build out a system based on standards that provides real-time evidence-based decision support, works offline, and thank you. Sorry about that. And integrates with our EMR. So like I said, we've built our EMR already. It's openEHR based, built on the Better platform. It's currently serving over 45,000 patients, and it's web-based. So it uses over 100 archetypes. So that works. But then we're going into the community where in many places, there's no network connectivity and, all those kinds of infrastructural challenges. So how do we, solve that problem? And so we settled on building a mobile app that we would use to empower our, community pharmacists, our PPMV vendors, so that they will be able to, administer care, have access to guidelines, and do things in a standardized manner. This is the architecture of our application. As you can see, we did a search. I don't think there's any equivalent of, the Google Open Health Stack in the openEHR community. So we use Google Open Health Stack. Basically, it's just a series of libraries that you use to build, mobile applications. It gives you capabilities to store your data offline, to sync to an online, Fire server, whether that's Happy Fire server or whatever, and then it also has capabilities to connect to your data to an SQL data store. And so those are the advantages we got with Google Open Health Stack. But we wanted to go a bit further, and so we also considered using ASR models. And so we tested different models. We wanted a model that could recognize African accents. We know that a lot of the models are pretty good with maybe German, UK, and all those accents, but we wanted something that would work with Nigerian accents. And then we also wanted the capabilities to work offline, the AI to work offline. Now, this was something that was not possible before, but we were able to test, Gemma models, Gemma 3N, and a bunch of other models, and we saw that they worked offline. Though we had challenges with that because, they require very high-end hardware. So for now, if we want to run Gemma 3N, we need tablets that cost, upwards of $1,000. But we wanted this to be very cheap. We wanted our system to run on, $200 Android tablets. So more on that later. And then, of course, we wanted bidirectional integration. We already have like our primary data store, which is openEHR, our system EHRCare. And so we wanted to implement bidirectional sync between this Fire-based mobile application and our system. So that's not yet done. We're in discussion with HiMed and OpenFire to use Hive Connect to achieve that. So using, on the one hand, Fire subscriptions, on the other side, openEHR event triggers, and then Hive Connect in the middle to sync that. And then, of course, like I said, on the back end, we have our openEHR platform, and then we are also using GraphRag. So GraphRag is a kind of retrieval augmented generation, approach where your knowledge base or your clinical guidelines, they are, chopped up. You insert that into a knowledge graph, and then the LLM uses the knowledge graph to retrieve context to be able to provide, the support. So it's not just naive RAG, it's graph RAG. There's some, if you've been following that area, there are all sorts of different approaches to RAG that aims to improve the efficiency. So, is my time up? So let me just skip this very quickly. So what's the setting? Like I said, we have a REACH program where we are already administering care to over 20,000 patients in low and middle income areas. And so we wanted to test out our system in that particular instance, in that particular program, those areas where we're already providing that kind of care. And so what is the patient journey? So we have basically two workflows. First workflow is a patient visits, one of those PPMVs. They have our tablet and the application on that tablet, and then, there's a workflow where you can use standardized forms, and, those are captured, and then at each step of the capture process, it is submitted to the AI, and then your recommendations are sent back, and then, you are able to now complete the record and then save that. That is saved to a Fire server and then, synced to an online, Fire server once there's connectivity. We also have a much more simplified process where, if you want, you could dictate. But basically, you capture vital signs, you ask for symptoms, and then beyond a certain point, it becomes like a back and forth, a chat. And so once you provide some details, you who is the health worker or the PPMV, once you provide certain details, it goes to the AI system. The AI system analyzes the conversations and then sends the next question, the next most important question, and then you ask that question and you keep going back and forth until you arrive at a diagnosis or maybe a treatment plan or maybe a bunch of lab tests that you need to conduct. And the AI does this by making reference to our clinical guidelines using the GraphRag system. So this is how it works. So again, we've seen, this is not yet, it's a study in progress. We've seen massive reduction in documentation errors increase in completing the medical records, and almost 100% compliance to medical guidelines, which is very important. And so, just like I explained, a lot of these, they're paramedics or they have some medical training. They are not fully trained. So, what they do with our guidelines, a lot of it is very error prone. But with our system, talking to those guidelines and providing feedback, we're able to improve the accuracy and, hopefully save a lot of lives. So maybe in EHRCON 2026, I'll come with a more, improved, a more complete picture, talking about how far we've gone on that. And so lessons that we've learned, we started from the foundation, openEHR, our system. We have to start from foundations. Standardization is the bedrock of quality. For us, offline is non-negotiable because of the kind of terrain, the kind of circumstance we work. We have to build stuff that is, reliable and can work offline. And then AI is an augmentation. The most effective role is supportive co-pilots, not necessarily taking over, the entire system. And of course, for the team that uses our application, we have to consider their literacy levels and other things. So AI can be, the best is to act as a co-pilot, not as, the entire thing. So this is our picture, and what we're looking for next, like I said, is to complete the bidirectional sync between our FHIR system, which is for the mobile app, and the openEHR. We're talking to HiMed and Hive Connect. Hopefully we'll be able to achieve that in a short time. We also want to complete the deployment of the models on offline on the device, because currently, like I said, they work. We've tested them out, but you have to use very high-end tablets. And for our own context, that's a bit of a problem. So we're looking at how to, in the next 12 to 8 months, to come up with a system that works, completely offline. And then, of course, we want to scale this to, probably the whole of northern Nigeria and then beyond, other parts of Africa. So thank you. This is our journey, and thank you very much.